to say that precision medicine and precision public health as terms have become a really big part of my life over the last year and a half is actually an understatement. It really has become quite a preoccupation for many of us in the coming School of Medicine, and actually not just here in Calgary. It has become a preoccupation for many in academic medicine because there is a fad on right now around these terms of precision medicine and precision public health. And so what I wanted to do was just tell you in a little bit of a narrative way in a storytelling way, a little bit how this has emerged in our parlance now in the coming School of Medicine, and how it has become an often discussed topic on the 7th floor of TRW, where John lives as dean, and in the leadership of the many research institutes and among many department heads, among people like Tara Beatty, who's Associate Dean for Graduate Education and needs to strategize. So many of us are talking about this entity. And I think it's really important for us to sort of wrap our heads around the entity. And I didn't get a chance to kind of get the vibe of what the mood is around this notion of precision medicine, precision public health, because I couldn't be here for the discussion. But I think as I talk, we can sort of maybe bring the two ideas together and sort of see where we land as you go into breakout activities. So last September, so September 2015, many of us came back from our summer vacations well rested, and our very first leadership forum session in early September with John chairing was where John says, I have a new signature strategy for the coming School of Medicine. And he presented to the department heads, the associate deans, and the institute directors a strategy, or the beginnings of a strategy and the beginnings of a document that was circulated around for today's retreat, which is a coming School of Medicine strategy document around precision medicine. And we all kind of looked at it, and depending on how much time people have, some read it in detail, others glanced at it, and kind of left it for a while, and we thought, maybe John will be distracted by someone or something, and then this will go away, and a month from now we won't have to talk about this. But then there was another leadership forum meeting where he talked about it again, and then Brenda and I, who have very productive monthly meetings, were talking about it, and then Brenda said, so what do you think about this precision medicine thing? And I said, I don't know, do you think it's real? And then Brenda said, yeah, I think it's real. I think people are talking about how there might be some recruitments around this precision medicine thing. So both Brenda and I started to really get to work on what is this. And we did a couple of things. One thing we did is we went to wise and aged counsel in our institute. So we went to Tom Noseworthy, and I won't call Lynn aged, but wise counsel. So we spent some time talking to Tom Noseworthy, Lynn McIntyre, and it was interesting because on the surface of things, and the other thing we did is we went to the literature, and in particular thought about precision medicine from a public health perspective, and actually in some ways they're the antithesis of one another. Like the notion of precision medicine, if you think about a narrative, and I know that because Matt and I talked a little bit last week about the retreat this week, I think we were both going to talk a little bit about framing precision medicine, and there can be different narratives. And there is a prevailing narrative of precision medicine that talks about using novel genomic testing and novel biomarkers and omics, and developing sophisticated new diagnostics and therapeutics that would be used in the clinical arena. And that narrative, which I might refer to as the sliver narrative, that's a sliver of what precision medicine, precision public health can be, indeed, I would say is really the antithesis of public health. And if people who are passionate about public health and work in public health know that, if we think about global health issues, and if we think about the social determinants of health, and we think of what determines health and well-being and what makes our healthcare systems work, that sliver of precision medicine is actually is actually kind of missing the bigger picture of what the burdens of disease are, where we need to be directing interventions. And there is a New England Journal of Medicine article that is really quite a stinging criticism of precision medicine. I'll also mention that Suzanne Tuff and a colleague, I think Nicole Letourneau, had written a very nice piece and thought-provoking piece in the Calgary Herald as an op-ed, raising similar concerns that maybe it's putting emphasis in the wrong place. And I think there's also a health economics lens where if you were to ask me what the biggest concern is in healthcare, it's not waiting times, as the Fraser Institute told us this morning. I think it's sustainability. We can't keep adding innovations that cost $49,999 per quality adjusted life year onto the cart of healthcare services that we provide on an ongoing basis, and continue to look for different innovations. And precision medicine is going to deliver innovations, BRCA testing, other fancy tests and ways of streamlining therapy that if we're just talking about new fancy approaches to therapeutics and diagnostics, that's not going to be a solution for health and healthcare. So anyhow, we were a little reluctant about this notion of precision medicine, and certainly when we had our strategic discussions with Tom and Lynn, we thought, boy, how can we fit precision medicine on the one hand and an Institute for Public Health, and so it was interesting. We, without getting into graphic detail of what transpired, we had some very good dialogue with John, and actually I told John I was going to sort of tease him over the course of these comments, but we had a really good discussion with John. Gerald Zamponi was involved in discussions, and we said we got into a discussion about what is the narrative of precision medicine, and we went beyond just that sliver narrative, and we found the writings of Khoury, and there's one of Khoury's articles. So Dr. Khoury is at the CDC in Atlanta, and has an interesting perspective, and he talks about precision public health, quote unquote. He still ends up always coming to an ending that refers to genome science, and let's have big cohort studies that collect specimen data and do molecular epidemiology work and get into refined prediction of risk. So in some ways, he stretches the concept of precision medicine and introduces the notion of precision public health, but still kind of brings it back to omics, which isn't bad. It isn't bad, but that's a narrower narrative. But then we found some other writings talking about precision medicine being first and foremost about rejecting the notion that one size fits all, and that approaches to intervening in patient care, that's in the clinical arena, in health systems, so that's in planning systems, or in population health and planning interventions for populations, that we should not plan interventions in a single way. We should really think about the complexity of intervening and think about the host, whether it be a person, a health system, or a population upon which we intervene, and tailor the intervention so that it has a better chance of working. And that narrative actually has many interesting examples of successes of intervening on healthcare systems and complex interventions and planning queuing methods so that you can improve efficiency of care. In risk stratifying patients, so not every single patient gets the same diagnostic test. And I think Matt would have talked, just based on how we were talking about our respective talks last week. I think, Matt, did you touch on some of those notions of applying one size fits all? Because I think with precision medicine, one way to define it is to say what precision medicine is not. And in healthcare systems, streamlining care and incorporating risk stratification and incorporating the harnessing of data from multiple sources, and really saying that precision medicine in many ways is not even about precision and medicine, it's almost more about data science, because it's about or information. information science. It's about creating systems that can harness information, process information, and then use that information to better refine determinations of risk and how to intervene, and then present that information to the individuals who are making a decision at the moment they're making the decision, not afterward. And in clinical medicine, that's sometimes frustrating. If you're in a clinic and you think about something after a patient's left the clinic, you actually have to do a lot of work to track them down. And it's sort of, I always say when we're talking about this, Alanis Morissette saying about the death row pardon 2 minutes too late. You want the information before it's too late. And so precision medicine is about creating paradigms where we do the work to understand what the determinants are of how a person will do, how a person will respond to treatment, how a person can be diagnosed, how a health system can be intervened upon, how a population can be intervened upon, and then analyze that information, present it to decision makers at the crucial moment when they need to make a decision, and then hopefully streamline your use of resources and improve not only the outcomes of people, but also expenditures, so reduce waste in systems. And indeed, we wrote that into a lot of the strategic documents around the precision medicine strategy. And it's actually quite exciting. And I know that the document that was circulated for today has a little bit of information about that broader narrative of public health. And the O'Brien Institute, with heavy input from Lynn, Tom, Brenda, Cello Tonelli, Melanie Rock, and some others, wrote a document that ended up describing 8 recruitments that have been approved through the coming School of Medicine's recruitment strategy. So to just give you the flavor of how it's a broadening of the concept of precision medicine. So one of the positions was focused on patient and family-centered care. So a scholar working in that domain, looking at notions of shared decision-making, the patient experience, measuring the patient experience and outcome measures around experience. A big data scientist or a data scientist. Big data is criticized sometimes as a jargony term that some people are rejecting, but a molecular epidemiologist, so that's a little bit in that sliver narrative of precision medicine. An expert in health policy, health economics, who will contribute to existing expertise. An implementation scientist, so that's in the domain of KT science. A models of care scientist who will look at how to integrate care across the continuum and how to improve integration of information systems. We also had a proposal for an ethical legal scholar who could look at ethical and legal aspects of precision medicine. That's sort of a little bit on hold, but it's certainly still on our, because there were only 25 of the precision medicine positions. And then there's also precision public health expert, and there the focus is on characterizing the social determinants, sociocultural determinants of populations, and then tailoring interventions to those populations. So there the notion would be if you're intervening on unsafe, like if we were to look at the patterns of fentanyl use and narcotic abuse, which are really hitting me hard this week as I'm working at Foothills Hospital. It's unbelievable. Like if there's any question in anybody's mind, is there something really real going on out there? It's crazy. Like it's really big things. Something big is happening, and we in public health need to be involved. But the approach in Calgary, because of our sociocultural context, is likely to be different than that of the downtown east side, and perhaps different than downtown Toronto and different than New York City. So context specificity invites a precision public health paradigm. So just as I sort of wrap up my comments, I just wanted to say, so I think that this broader narrative has been really good. And I also want to say it's actually really changed the culture of how the 7 institute directors deal with one another, and how the school operates around strategizing around positions, because as we all figured out what this was, it no longer became about the O'Brien Institute fighting for its share of positions and making sure that Sam Weiss and HBI don't run away with all the positions because they're so damn good, etc. Because they are good. We've copied them in a lot of things. It became about defining positions that weren't about which institute bucket you fall into. It became more about creating a harmonized matrix of positions. And that's been really, really, really very good. And I do wish, and I think I've said this to John in person, I wish that we had this strategy in place when Jeff Cumming came with the money, because there we were still in those buckets where we knew we were strong in inflammation and we were strong in neuroscience. And so the Cumming donation went in those directions, and I hope that it can sort of, and I think it probably can be redirected somewhat to align a little bit more with the precision medicine strategy. I think the one reflection I would have too is, there's two ways to think about this. Is this just a fad that John Meddings kind of jumped on to, not that early, like Barack Obama was about 2 years ahead of John Meddings on this, or announced the precision medicine strategy. We don't know, like maybe Donald Trump has pulled out of TPP yesterday, or he announced that, and he's going to make another YouTube, I'm sure. I'm getting out of precision medicine. It's a disaster. So we don't know what Donald Trump will do, but John's going to keep us there. So, I mean, one view of precision medicine is to be jaded and say, well, like everyone and their dog has a precision medicine strategy now. Like, and that's true. Like medical schools have all, it's in there, everyone's talking about it, and there are some lessons from history, and I've spent a lot of time chatting with Jesse Hendricks. Everyone knows Jesse, I'm sure, and he has a background in philosophy, and he likes to think about philosophy of science, epistemology, and really interesting conversation. So everyone should buy Jesse a coffee in the next 6 months. I hope you drink coffee, Jesse. And evidence-based medicine, quote unquote, was introduced back in 1992 by Gordon Guyatt and colleagues at McMaster University. And they were criticized like really heavily because people said, this isn't new, the idea of finding evidence and making clinical decisions based on evidence so that your patients do well, duh. So some people criticized EBM, and there was truth to those criticisms, but the paradigms of EBM helped move us forward. That's my take. Implementation science, KT, the whole idea that you should take knowledge and move it to people who make decisions so they can make better decisions. Is that a good idea? Duh. Yeah, that's a good idea. One size doesn't fit all. Precision medicine, precision, duh. That's a take on it. I don't think that though. Like I really do think that yes, we have formed a strategy that's a little bit of a strategy that everybody's rallying around. I think it's still early days in the precision medicine journey, and I think that the way we've rallied around the CSM25 has been actually really, really quite exciting, and it's been a maturing of this faculty that I think is really, really positive. Unbelievable that in a recession economy we get to recruit 25 new people. I'm shocked, actually. I don't even know how that math works, so whatever, we'll just go with it. And we, in public health and working with Brenda and others, we, like in some ways, a jaded view would be, oh yeah, Ghali and Himmelgarn just figured out how to play this game. John Meddings created rules, and we've done pretty well with the Cumming strategy. That's the jaded view. I actually think that what we've done is we've pulled this precision medicine, precision public health concept out from the sliver to defining it as really about harnessing information so that we can make decisions that are tailored to the patient or the health system or the population to which they're being targeted, and we can really get at some innovations that can make health, that can advance health, and better health in healthcare is our mantra in the Institute. And with that, I'll just end and say I think this has been a really positive thing. I look forward to the discussion and how we can really shape this notion for us, because it's still a new paradigm that we're working within, and I think we can make it our own and make it something really powerful for us. So. with that. Thank you.